Hey everyone, welcome back to the channel. So today we're going to clear up a topic that comes up a lot in both exams and clinic, and that's apexogenesis versus apexification. I know those names sound kind of similar, and yeah, they both deal with immature teeth, but they're actually pretty different, especially when it comes to why we use them and when we use them. So let's just break this down, starting with apexogenesis. All right. So apexogenesis is something we do when the pulp is still um, vital, like the tissue's still alive and capable of healing. The goal here is to let the root keep developing naturally. We're talking about the continued thickening of dentinal walls and closure of the apex. So yeah, we want the tooth to finish what it started, but under protected conditions. This is part of what we call vital pulp therapy. So like say you have a young permanent tooth that's been traumatized or has deep caries, but the pulp is still responding positively. This is where apexogenesis fits in. Now, when do you actually choose to do apexogenesis? So the pulp has to be vital. That's like the big rule. No spontaneous pain, no lingering pain with stimuli, no swelling, no fistulas. And the bleeding, when you access the pulp, should be mild and easy to control. On the radiograph, you shouldn't see any periapical changes, right? The root should look open but clean. But if the pulp smells bad or there's pus or you see signs of necrosis radiographically, that's not a candidate for apexogenesis anymore. That's when we start thinking about the other approach, apexification. But before we get there, let's walk through how apexogenesis is actually done. So first, you numb the tooth, of course, and isolate it with a rubber dam. Then you remove the caries and get access to the pulp chamber. You're only removing the inflamed coronal pulp, not touching the healthy radicular pulp if you can avoid it. You can use a spoon excavator or a sterile round burr under magnification. Then you use a saline moistened cotton pellet to control the bleeding. If it stops within a couple of minutes, great. You place a biocompatible material, usually something like MTA or calcium hydroxide, right over the pulp stump. Then you seal it temporarily and schedule the patient for follow-up appointments to monitor root development on the radiograph. Once the root is fully formed, you might just leave it alone, or you could go ahead with root canal treatment if needed. Okay, now let's talk about apexification. This one's used when the pulp is non-vital, so the tissue is already uh, necrotic, but the root's still immature. It hasn't finished forming yet. The idea here is to stimulate a calcified barrier at the apex so that when you do your obturation, there's actually something to condense against. This falls under what we call non-vital pulp therapy. And yeah, most of the time, these are teeth that were either traumatized or had deep caries that went untreated. Traditionally, we used calcium hydroxide for this, and it still works. But now, MTA is used more and more because it's faster and more predictable for forming that apical barrier. So how's it done? You still start with anesthesia and isolation. Then you get access and you clean out the entire canal, irrigate with sodium hypochlorite, rinse with saline, dry the canal. Then you place your calcium hydroxide paste close to the apex, not extruding beyond, but around 1 to 2 millimeters short. The tooth is then sealed temporarily and the patient comes back every few months. So you can check for signs of apical barrier formation on the x-ray. Once that's confirmed, you go ahead and fill the canal as usual. Now, if you're using MTA, you can sometimes do this in fewer visits. Once you see or feel a hard barrier at the apex, you're good to go. And by the way, if you're using a hand file and you feel a definite stop, even if the radiograph isn't crystal clear, that's often enough to say that a barrier has formed. There's also something called Frank's criteria. It's basically a checklist of signs that tell you if the apexification is complete, like radiographic evidence of barrier formation or a definite stop when you're instrumenting the canal. Even if it doesn't look like textbook closure, you can still proceed if the barrier is clinically solid. All right, that's your deep dive on apexogenesis versus apexification. If this helped clear things up, go ahead and give the video a like and um, don't forget to subscribe to Dental School for more clinical content that actually makes sense. I'll catch you in the next one.